Hello, everyone. Welcome to the last session. My name is Dr. Haider. I'm from Rutgers NJMS, and I'll be presenting today about minimally invasive esophagectomy and our analysis regarding racial disparities in it. But before I start, I want to thank Sages for giving me the opportunity to present here. I have actually no disclosures to reveal, and I'll proceed with my slides. So esophageal cancer is like one of the most important public health concerns worldwide, and esophageal cancer in particular is the 8th most common cancer. Particularly in the United States, about 17,000 new cases are reported every year, with 3-to-1 ratio of men to women for this particular cancer. When we think of esophageal cancer, we think of two particular types, adenocarcinoma and squamous. And the etiology of them are different, but they also overlap. So for adenocarcinoma, we notice like Barrett's esophagus, GERD, or smoking, alcohol, obesity become some of the risk factors. And for squamous cell in particular, alcohol, smoking, diet are some of those things that become variable in sort of like incidence of squamous. In terms of the treatment plan and the modality and diagnosing, esophagectomy remains one of the most common procedures for the curative resection of the locally advanced adenocarcinoma or esophageal cancer. Now, over the course of last 20 years, there's been dramatic improvement in treatment modalities. And as technology has advanced, we have advanced techniques now ranging from laparoscopic and robotic skills, allowing us to do esophagectomy. Traditionally, open esophagectomies has been the procedure of choice for esophagectomy. However, currently, the data is controversial between the two regarding advantages and disadvantages between the two procedures in particular. So minimally invasive esophagectomy, some of the pros regarding that is that it has fewer complications, it has a shorter length of stay, and whereas some other studies have demonstrated comparable results between the two. Our goal in this study was to analyze if there was racial disparities in context to the operative approach using the NISQIP database. So we used database from 2012 to 2019 and analyzed some of the preoperative variables regarding patients' comorbidities and analyzed their postoperative outcomes. The two main statistical models we use is univariate analysis and propensity score matching, with the goal of making sure that we can match black and white patients as close to one another so we could appropriately do the analysis. So these were our results from the data from 2012 actually to 2019. We had about 9,000 total cases of total esophagectomy. So we excluded all the benign cases from our study model and ended up having 7,800 cases almost, out of which 96% were self-reported white patients and about 3.7% were only black patients. Now, after doing the propensity score matching of 5-to-1 analysis, and this allowed us to correlate one black patient or 5 white patients that were like completely similar in terms of their comorbidities. So they were balanced as close as we could get. And these were our numbers. It was 1,400 for the white patients and 285 for our black patients. And these were our results. And the major thing that I want to guide you and like take home message from this slide is particularly that there was no significant racial disparity in access to minimally invasive esophagectomy between the black and white patients. This is table 1 is particularly regarding our demographics, which is just showing all the comorbidities and our basically open approach to surgery. And we see that the numbers between the two are very similar. When we do propensity score matching, our findings are consolidated and reaffirmed, demonstrating that there was no significant differences between the two populations in access to the minimally invasive approach. Then our next question was, if there's no differences in access, are there differences in outcome for these two patient population groups? And the reason we've chosen blacks and white in particular is because these are the most represented group in our analysis in the NISQIP database. And what we find here in the complication aspect is any complication was higher for the black patients. There were severe complications that were higher, and there was a higher risk of mortality for black patients undergoing esophagectomy. Now, since the access was not different between the two groups, we were unable to do a mediation analysis that would help us demonstrate if these postoperative complications were in some way mediated by the open approach or not. In terms of understanding why these postoperative outcomes and complications do occur, I've highlighted 4 major areas because I do think it's multifactorial, with major economic barriers, insurance status being a marker of differences in outcomes between the two populations that has been demonstrated in multiple studies on colorectal surgery and cancer surgeries. Secondly, access to cancer treatment has been demonstrated to has shown that Black patients have fewer access to cancer centers and treatment modalities that allows for appropriate care. Third thing that I've noticed is access to the high-volume centers. In Europe, they've centralized data points that have allowed patients with esophageal cancer to come and get treatment at high-volume centers. And lack of access to these high-volume centers has put minority populations at disadvantage, resulting in which I do think could have resulted in higher postoperative complications. And lastly, but not the least, implicit bias in our clinical care that can potentially be affecting the clinical outcomes in our patient population. So in conclusion, race, we conclude, is an independent predictor of the postoperative complications, but not the operative approach in esophagectomy in particular. Thank you.